So good afternoon. I'm Dr. Liesl Bryant. I'm one of the risk management advocates at the Trust, and I'm delighted that you're able to join us today for our 25th Risk Management Roundtable. As a Trust policyholder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits that policyholders receive through the Trust. I'm one of the 8 advocates, and I'm very excited to be joined today by 2 of my fellow colleagues, Drs. Jeff Youngren and Mark Martinez. So on that note, let's go ahead and get started. Welcome again, Jeff and Mark. Delighted to be here with both of you. As you know, we're going to start with just a couple of questions that come from the calls we have, and then we will dive right into the live questions. So Jeff, I'm actually going to start with you. One of the things that we get a lot of calls on, right, is what happens when clinicians need to end care or end psychological services with a patient. And so I'm wondering if you can start maybe first with what are some of the myths that have been associated with the responsibilities of the psychologist when ending psychological services with a patient, and what risk management recommendations would you offer to clinicians?
It's a great question, actually, because I wrote it. But it really, I think that one of the things that I've learned having done this for 40 years is that people keep looking for rules to help them make decisions in systems that don't really have rules, that they want some kind of concrete thing that they have to do. And what we've learned is that risk management and duties to patients and things we need to do to end relationships are a constant question about individuals. Somebody comes into you to see you once. Somebody's seen you for 5 years. It's very different, and I've done so many consults with individuals who have come out of graduate programs where the graduate program and their ethics and law has told people that when you terminate a patient or when you end the therapeutic relationship with a patient, that you must give 3 referrals. That's always been rather amazing to me when, in fact, there is on the website of the APA an article that says that is absolutely wrong. It's been there for years. There is no rule of 3. Who made that up? Why 2? Why not 4? Somebody goes like, well, let's do 3. That's just not correct. What a person has to do is to do an adequate referral, to have your behavior appear in the wiggle word reasonable to other individuals, not agreeable to every individual, but reasonable. And so sometimes a referral to an individual back to their network is more than adequate because you don't know who else is in their network. And why would you give them the names of 2 individuals they can't see and they're not in the network in order to accomplish this number 3, which was made up somewhere along the line. It has to be a reasonable referral. People worry about if somebody comes once and then they don't come back and they miss their appointments, do I have to send them a letter and make 3 referrals to them? No, I mean, probably appropriate to reach out for them in search of that kind of reasonable behavior. What is the reasonable behavior of an individual who is ending a therapeutic alliance? Do you have to have termination sessions with somebody? No, you don't always have to have that. If they came one time, how do you have termination sessions with them? So I've always been a proponent, and people who've attended my workshops know of think about it. Think about what is the best way to approach this so that my conduct is reasonable. Not look for somebody deciding that some concrete rule is in place.
Yeah, great, Jeff. Gosh, you hit on many good points there. Mark, anything you want to add to that?
Yeah, I agree. I think those are all really great points. It brings to mind for me a related point that we talked about some of the myths on the psychologist side. I sometimes I'm sensitive to some of the myths that the patients have. And I think one that I hear a lot is there's a lot of resistance sometimes when there's this unilateral end of treatment. And I think at the base of that, for a lot of patients, it's having to open up again, make themselves vulnerable, and revisit or restart with somebody new. And in order for the psychologist to help dispel that myth on the patient's part, that can be worked in, you know, assuming that there's an established relationship and you're going through a typical type of a closure process, that you can try to facilitate a warm handoff, try to make it easier for the introduction phase, ideally, to try to dispel some of that myth. And so they don't have to necessarily start from scratch. The new provider could perhaps be caught up to speed somewhat by the existing provider.
Yeah, yeah, that's an excellent point too. And I appreciate sort of what you're both saying in a way is that there is no cookie cutter approach here. It's not a in every case do X. And so, Jeff, I think you said this too, that it really needs to be a case by case decision based on factors for that particular individual. So great. Okay, Mark, I'm going to come to you next with our next question. As you know, we get many, many calls about issues about how a clinician should respond when a patient is requesting that the therapist or their clinician write either a letter or complete forms for the patient to receive disability benefits or disability leave from work, right? So can you speak to some of the risk management considerations in that context? What should a clinician be thinking about when they think about whether they're going to say yes or no to doing this?
Yes, certainly. So this type of request is typically asking for an opinion from a provider about the existence of a mental health condition that affects the patient's ability to complete work-related tasks. As a treatment provider, offering an opinion like this runs the risk of extending yourself beyond your role. And it's often hindered because the data necessary to form or support those opinions is very limited or non-existent. So assessing how a mental health condition affects an individual's work capabilities is typically left or best left to an experienced evaluator. So typically it's going to be a forensic psychologist, just because this type of a question, if it's disability in particular, that involves regulatory and administrative type of questions. Now, so with this in mind, if you were to receive a request like this, I would advise that the treatment provider begin by discussing the request with the patient, explaining the limitations of your role and the type of information that you can provide. And what you can provide may include details from the treatment plan, any assigned diagnoses, treatment response, session attendance, and so forth. I recommend that the treatment provider avoid conclusions about the patient's ability to work, again, citing your role's limitations and insufficient information to answer such a question. And if you were pressed to answer a question about workability, consider limiting this to statements that were made by the patient. If ultimately all of this is not sufficient, then consider offering the patient referrals for an evaluation. And lastly, I strongly recommend documenting this process in the patient's chart, including the rationale and the information you provided. And I also want to add that the time you spend on writing this type of letter, assuming that you do decide, can be charged. Ideally, fees related to time devoted to this type of task that falls outside the customary task will be detailed and agreed upon in advance in the informed consent at the outset of treatment. But regardless, before charging for this time, I think it's wise to discuss with the patient and document their agreement, even if it's previously agreed upon. So it's also important to ensure that all billing practices are consistent, of course, with insurance contracts and other contracts that might be in place.
Yeah, great points, Mark. Jeff, anything you want to add there?
Yeah, this is another area that has a tinge of gray to it, that we have to respect. I entirely agree with Mark that those questions are really administrative / forensic questions usually. However, let's say a patient of yours comes in and they just heard that their wife and children were killed in an airplane accident, and they clearly can't go to work. Is it appropriate to tell them to not go to work? Is it appropriate to verify that they shouldn't go to work briefly, given the crisis at hand? That's a reasonable thing to do, but to make clear to the individual that you're not going to shift your role into something that's administrative in nature, so that the evaluation later has to be done by somebody else. So, I mean, this is not black and white. It's, you know, a lot of it's black, a lot of it's white, but there's a lot of gray here. Or somebody comes in and they can't function. Should you give them disability? That's another area that people ask for. And the answer is briefly, you can do that, but you need to make sure they understand that you're not going to do it regularly or you're not going to do it again. They need to go elsewhere to answer that question because that's not your job. Um, to send them somewhere else when they're devastated and unable to function is really, I think, a violation of beneficence. But clearly setting the expectation about what you're going to do and not going to do is what you do. So, I'll fill out this disability form one time. I'll disable you for 2 weeks. You need to take care of it beyond that, to me, is a reasonable act because disability is like tar. You get it on your hand, you can't get it off unless you really manage the initial contact with the tar. And so, it grows and grows and grows. So you end this, you do the humanistic venture of telling the individual you'll help them briefly here because that's the appropriate thing to do, but you're not going to shift your role. You're not going to get into role conflicts. You're not going to write letters. Those are not the functions of a clinician.
Yeah, well, I agree. I mean, I agree with both of you. And I think what you've both sort of laid out is some of the complexity here, right? That there might be a little bit of gray in some instances, especially, I think, Jeff, like you say, where, the whole family is killed in a car accident or
Yeah.
plane crash. I mean, really tragic situations like that. I think there is an argument to be made to write that letter and that is a beneficent thing. I think it can also be more complicated if you've been seeing a patient for a year and they have been working, but now they say they can't or they don't want to, and it's a little bit more unclear as to what is the issue and why are they not, or many calls, right? I'm sure you guys have taken them too. I've had calls where the clinician doesn't think the patient needs disability, right? So I think again, this is one of those cases where there's complexity. It's always a good idea to consult, right? That's one of our main risk management strategies. So if you feel like you're in a situation you don't know, I think we'd all recommend consulting, especially if it's gray. And then Jeff, I would certainly agree with you, and I think we'd all agree that those later cases should not be done by treating clinicians, generally speaking. So great. Okay, Jeff, so let me come back to you then, and I want to follow up again on the issues of ending care. Both, or maybe including like maybe it's mutual, but also including when it's, as Mark said earlier, that unilateral termination, meaning that the clinician is ending care or services with the patient against the patient's desire, that the patient wants to continue. And I know, Jeff, you often talk about this process of ending care as being dynamic, and I wonder if you can explain what you mean by that.
Well, for sure, the therapeutic alliance is dynamic. Eric Harris and I have written articles about this, where it's not like once the patient comes into your office, your duty to that individual, which is a legal term, your duty to that individual is exactly the same as it would be if you'd seen them for 4 years. That's simply not correct. That duty changes. That very example is a good example of the dynamic of duty. So, if I've done a lot of consults, you all have as well, somebody comes one or two times and they disappear, and then people become, all up in the air about, what do I do? Is this going to be abandonment? I mean, that's utter nonsense. If they're emergent, of course, but we're talking about the person that comes once or twice, doesn't come back, doesn't return your phone calls. What is your duty? What your duty is maybe to send them a letter and let them know that you're not going to see them. I would say that most people just don't do anything, and most of the time that's not a problem, but problems happen. So the existence of a letter clarifying what you're willing to do is probably a reasonable risk management strategy, saying you came twice. And I just want you to know that I'm happy to see you again, or happy to give you a referral if you'd like. And actually, that's enough to say. You don't have to go. You need to go see Mark Martinez, and this is his phone number, and you don't have to do that. But if you have someone in therapy for 3 or 4 years and therapy is stuck, it's not going to continue, you don't think it's very successful, and you want to transition them, then the duty is very different. You have to engage in a much more formal termination. Denise Davis wrote a wonderful book on termination about the complex nature of terminating a relationship that's been around a long time. And then it's just very true that if you don't discharge that duty well, you actually are vulnerable to various kinds of claims that can make problems for you. So how do you discharge it? Well, you send them a termination letter, you give them transition, you do termination sessions, whatever, to adequately shift them over to another therapist who may have a skill set you don't have, or may have an idea to do things that you can't do. And that's appropriate. There's nothing wrong with that. Um, what do you do if the patient objects to termination? Well, you don't have to see patients that you don't think you can help. Or more importantly, if patient's behavior is inconsistent with the expectations of good conduct, then you don't have to see them. If they threaten you, if they stalk you, if they don't pay you, you don't have to continue to see them. We don't have to work for free. We can terminate them. There's a very, very good case, public record, out of California called Ensworth versus Mulvane, where the psychologist wanted to terminate. The patient stalked her, appeared in church behind her, said she was going to set herself on fire in front of the therapist because the therapist wouldn't continue to see her. And eventually the therapist got a restraining order. And this, you can look this case up, got a restraining order. And so the patient then sued the therapist for a violation of confidentiality by getting the restraining order. And it went into the California courts, and the appellate court said, no, 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 no. You don't get to do whatever you want and assume that the therapist still has the same duty. So threats, lack of payment, things that are a breach of the therapeutic contract are grounds for termination, and termination in those circumstances is different. And there is a case to be made for things that occur where you never see them again. Um, and those are cases where you're threatened. If your health and welfare is being threatened, you don't have a duty of care. So there are lots of good articles about this, about the whole concept of duty. So it's a dynamic. It changes depending upon the circumstance.
Yeah, very good points. Mark, anything to add?
I really like that. I think it emphasizes the importance of this general type of mindset that is responsive and flexible to at least three large important factors: that the provider's ability, perhaps, or the provider factors, the patient's needs, the factors that they're bringing into the situation, then the circumstances, and trying your best not to follow some sort of strict rule as you're going through this process, but contour the process to meet all of those needs in the most reasonable fashion possible. I really like that. I appreciate it.
Yeah. Yeah, thank you. And I'll just add to, I think the dynamics, sometimes, we as the clinician can have our own reaction to patients. Maybe we're angry or frustrated or whatever, and it may be that we do need to end care. But that's, again, a good place to maybe consult, making sure that our own feelings don't necessarily cloud our judgment about how we do it. Not that we don't do it, because I completely agree with you, Jeff, that sometimes we just have to end care, end of story. But as we all know, I think how we do that can also make a big difference. So another place where consulting and of course documenting is very, very important. Okay, Mark, so last question to you before we start taking some live questions. We get many calls on multiple relationship issues with patients. I think last week, it was my week for issues with this, calls with this. It was one after another after another. So, and there's many ways this shows up. Take, for example, a clinician that's been seeing, say, patient A for a while, and then now now they get a new patient, and then they learn that either those patients are close friends or romantic partners or those kinds of things. And there's many other ways, as you know, right, that this can show up. But can you speak for a moment to maybe what sorts of things clinicians need to think about when they're thinking this through, and what are the risk management strategies that you would recommend?
Sure. Yeah. So as a starting point, I think it's essential that we all remain sensitive to the possibility that multiple relationship will develop or is potentially even already present in our work. And it's also crucial for us to recognize that these relationships in and of themselves are not inherently problematic in all cases. So if you were to find yourself in a situation where you're serving in multiple roles with the same person or somebody closely associated with them, I think it's helpful to look to the APA Ethics Code, specifically 3.05. And you can ask yourself some questions based upon this standard. So first, ask yourself, could this situation impair my objectivity, competence, or effectiveness in some way? And next, might this situation exploit or harm those that are involved in this professional relationship? So to navigate this type of a situation effectively, I can't emphasize enough, again, some of the foundational risk management elements to consider consulting with an experienced colleague. And what this would allow you to do is get a different perspective, perhaps gain a more thorough appreciation or analysis of these questions and how it's interacting in the situation you're in. If you were to determine that an existing professional relationship must end because there's a conflict that cannot be mitigated in some way, it's imperative that the clinician do so without breaching confidentiality. So, as an example, this could involve a clinician informing a patient that a conflict has arisen and that requires you to facilitate a transfer of their care. And unfortunately, because of the nature of this conflict, you're not free to divulge the details. And you can process that with the patient because there may be some uh, confusion or questions that remain clearly, but I think making sure that you maintain confidentiality is going to be extremely important. And also, if your initial analysis does not reveal a conflict, it doesn't mean you check the box and move on and don't attend to it anymore. It's important to regularly assess the situation and monitor for the potential emergence of a conflict and ensure that you stay vigilant and address any issues promptly. You have a better opportunity to mitigate before it gets to a clear conflict. And finally, and importantly, the clinician should document this analysis and the process you followed to assess whether conflict is present from these multiple relationships and what you did to arrive at your final conclusions.
Yeah, great. Thank you, Mark. Jeff, anything to add?
This is another great area where there is wiggle room. It really, there are many articles written about duality and in small town communities. The rules in those communities are different than they are in Albuquerque or in New York City, because the social structure is different, the access to care is different. So in a small town, you may be treating your banker in psychotherapy because there isn't anybody else to do it, and you can't send them, 50 miles away. They won't go. So does it look reasonable to do that? That is, could you explain to another individual with a high probability that they would agree that you needed to do it, and this was why you did it? Now, that doesn't mean that you're allowed to violate extreme conflicts that come from duality. You can't date your patient in a small town. You can't have sexual relations with your patient in a small town. Those small town exceptions don't apply to those kinds of things. But they do apply to circumstances where there is a requirement to kind of think about what really is the problem here. Because one thing that people need to remember is there are only two ways you're going to get into trouble. You're going to have a civil suit, which requires damages, or a board complaint. And so those are your areas of risk. And if there are no damages, the civil suit's out the window. Board complaint, probably much more common. And so again, with your attorney, if somebody complained about the fact that you made a decision about seeing somebody who was your banker, or you bought a car from somebody who was your patient because that was the only Ford dealer in town, and buying a car someplace else in a small town is the kiss of death. Those are reasonable things to explain to an adjudicatory forum. So a little wiggle here again. God wants us to think, we need to think.
Yes, no, I love that. And again, so I think we're talking about a lot of situations today with complexity, some wiggle room, but that doesn't give a free for all, right? I think some of the
Oh,
things that
no.
I respond to is when clinicians say, well, of course I can do it, no big deal, or when they haven't thought it through. And so, yeah, I love, Mark, that you referenced the 3.05 in the code because that actually gives us that very clear analysis that we have to do for each time. And I will just say before we start taking some questions, it references back to Jeff to what you said because the code actually uses the language of if it's reasonably expected to impair. So it doesn't have to be 100%
No.
guaranteed that it will impair, but nor does it have to be, just a 0.001% chance of impair, right? It just says reasonably expected. And that's where, again, I know I've said this, and Marcus, we'll say this many times, but consulting is a really good idea. Because if just as Jeff just said, if someone else can reasonably, it makes sense to them, you can maybe be sure you're on more solid foundation there.
Yeah, there's a lot of literature out here about this, and Mike Gottlieb's written a lot of very prominent articles, not big long tomes that you have to drag yourself through, but really common sense kinds of things. I mean, really, the basis is somebody saying, that makes sense to me, and somebody else saying that makes sense to me, and then documenting that, of course.
And just all I want to add is because I mean I know we've all seen cases go very badly in here, but is it reasonable, but also really thinking about potential ways it can go bad and potential for harm. I think that is really important that the
Mhm.
clinician really think that through because we've seen cases where people have been harmed. So I think just looking at both sides and then making the best decision we can. So all right, well let me head to some of the live questions. The first one is, what are some of the ethical issues when thinking about retirement from practice? Mark, why don't I let you start on that one?
Good. A real short one, real short
Yes,
answer for this.
right.
Now, I get,
Tiny
we get,
topic.
we get this call a lot. It's not surprising. I usually start off, I think for me, because there's so many moving parts in this, what I typically will go to, Joe Stropo did a great presentation on retirement closing practice that's available on demand through the trust. But beyond that, I also really like APA's checklist for closing your practice. If you were to just to Google APA checklist for closing your practice, there's a PDF. Why I like this so much is because there's so many elements to this that it puts it into a chart format with a target date, when you've accomplished it, you can check it off. And I just like how it puts it all in one spot, makes it much easier to tackle one by one. So I think it really depends upon the nature of your practice, group practice, private practice, whether you're taking insurance or not. You want to think about contracts, whether you're leasing a building, closing the lease. Of course, you want to think about patients and closing up, transferring care, give them sufficient time. Uh, Occasionally, you'll get a call from somebody who is just starting the retirement process or wants to know how to start and they want to do it next month. That is a huge lift. I don't know how you could do that. I had one today where I was worried that may have been the timeline, but they said, I'm anticipating doing this within the next 3 years. So that's perfect. You have plenty of time. You won't feel overwhelmed. You can take this step by step. But you want to think about patients, of course, closing treatments, maintaining those records as required. I think it's an amazing time also to update or create a professional will to have that in place so that you have backups in case something unexpected happens. Life happens whether we plan on it or not. And so I think those are some general ones. And in addition, because there are some very jurisdiction specific nuances that when I close open practices, I may have missed. I'm very happy that I relied upon consultation with local attorneys and accountants to make sure I was able to check all the legal and accounting boxes as well. And I'm sure I left off a bunch. Are there large ones that Lisa, Jeff, you can think of that I'm sure I didn't go through the comprehensive list, but are there others that you think would be important?
I think you hit on the majority of them. And I love that you referenced Joe's webinar. Also, we'll just say for a resource, Joe Scropo also wrote a journal article. I'm sorry that I'm blanking on the name of it, but if you Google Joe Scropo and article on retirement, you'll get that as well. And there's many, many good resources in that. Jeff, anything you want to add there?
I think Mark covered it. I mean, really, it's a complex process that requires some thought. Obviously, you close a practice with a plan in mind. How do you transition people out of your caseload? Who do you send them to? Do you get the authorizations to do that? The maintenance of records, you still have an obligation to maintain those records, or with their permission, let someone else maintain those records. So it's a complex area. It's not like you just close the door and go home, and that can get you into difficulty. I've seen licensing boards reactivate a license with somebody who hasn't managed a termination or closure well. Rare, probably more likely to get hit by a meteor, but but those kinds of things can happen.
Yeah, no, excellent point. And it reminds me, I want to just mention this here. We won't go into depth, but just to make sure people are aware, Mark, you sort of targeted it with the idea that there are state laws, right? So be aware there's different state laws for what you're required to do when you close a practice or retire. Some make you put, notices in the newspapers. There's also state laws, as we all know, on how long we keep records. And I want to note here that if you are practicing in other jurisdictions, so for instance, if you're practicing under SIPACT and you have patients in other SIPACT member states, you're required to follow the laws of those other states, the state where the patient is. So for things like records, maintenance, and that kind of stuff. So lots of complexity here. For time, we are going to move on, but I wanted to just highlight that too to make sure everyone was aware of that. Okay, Jeff, it looks like this one's on abandonment and patient ending of care. So here's the question, I'll send it to you. If you, meaning the clinician, deem the treatment no longer medically necessary, but the patient wants to continue, and say with an insurer such as Medicare, one cannot see the patient outside the insurance system, how do we move to closure without abandoning the patient?
Whoa, that's a great question because it seems to me that you just said that you're not doing any good for that patient, that your skill set doesn't work for what their needs are. The insurance is an administrative issue. And, that doesn't have anything to do with the delivery of healthcare. I think that's be great to hear Lisa and Mark talk about this because I believe that you can't deliver the service to an individual when you don't think they're benefiting from it and you don't have the ability to meet their needs. That's an ethics violation. That can get you into real trouble. The analogy is kind of like if you go to an internist and you need an appendectomy, and the internist says, "Well, you need to go see a surgeon." I can't do the surgery. You need to go to a surgeon. The patient says, "Oh, no, 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 I want you to do it, doc." Well, psychologists go like, "Well, oh, Bill, I better rethink that." Well, no, it's still, they don't understand what we can do. They don't understand what you can do. Do you try to manage it well? Yes. Do you try to avoid adversity? Yes. But to deliver unnecessary services is another kind of violation. So you say, I'll see you one more time, and I'm going to refer you to this individual because they do DBT or they do whatever, or you need to see a psychiatrist because medication seems appropriate, whatever. And they go like, no, I don't want to do that. Well, you have to be very careful to agree with that. Abandonment is a term that people toss around but don't really understand. And so it's not transitioning somebody to somebody else when they object to it. That is not abandonment. Abandonment is not delivering care to somebody who is in need and not managing that case appropriately, not making a referral when somebody is in need, not sending them to an emergency room when they walk through your door with a gun in their hands, or getting the police. Those kinds of arguments become abandonment arguments. And I think abandonment as a disciplinary action, although there are some cases that have occurred, is relatively rare. So it's worse to feel that you're trapped in delivering services to somebody that are unnecessary.
Yeah, I think you get it a couple sides because our code actually says if we're not able to provide effective care, that we do need to transfer that person,
Hmm.
right? So, yeah, Mark, did you want to add anything there?
when I was hearing this, I think maybe thinking of the other side of the coin, and that when I see no longer medically necessary, hear that, I'm thinking that the clinician is determined that perhaps they're at a point where they're no longer in need of the treatment services. So when I heard that, I was thinking the patient thinks that there's an ongoing need, but the clinical impression of the provider may be that they're at a point where I don't no longer think that they need to continue. And I think that also speaks under standard 10.10 in the APA ethics code that we transition toward closing treatment when they're no longer benefiting, they're getting worse, or they're at a point where we no longer believe that they need ongoing treatment. And so if that's the case, then I think, again, ongoing clinical consultation specifically with an experienced colleague to help facilitate how you can communicate that, perhaps role play, communicate how ethically you're at a point where your clinical impressions are indicating that this person's no longer benefiting or needing treatment at this point. You can and try to bridge that gap and arrive at a middle ground. But I agree with both what Jeff and Lisa said as well.
Yeah, no, very good points. And again, I want to just underscore, like, there is no cookie cutter approach. So we may give we're trying to give sort of pieces and recommendations here, but please remember the main take home is it has to be case specific.
Mhm.
And there's no way, of course, we can address all of those cases. So consulting is a really wise thing to do. Jeff, I'll hand this one to you too, because it's also on the issue of ending care. What can you do if you can't find an adequate or appropriate referral?
That's a great question. If you can't provide an adequate referral, then the small town rules may be implemented that you just do your very best because there isn't somebody else to refer to. But people get mixed up about, I'm responsible for the fact that the insurance company doesn't have someone in the network that's an adequate referral. That frankly is not your problem. Managing the patient is your problem, and they may have to make a choice about seeing somebody outside of network in order to meet their needs because somebody is, spot on an expert in dialectic behavior therapy, but they only do it on fee for service, and that's your referral. You can't and shouldn't just see them because you can't find somebody else to see them. But it's still a little gray. Can you be supportive? Can you try and help them in ways? Yes, but if it isn't what you can do, one would argue it's even potentially malpractice to try and fit the bill, if you will.
Right. Right, and I think sometimes you can give more general recommendations, like call your insurance company or call the local community mental health center or those kinds of things, rather than necessarily a specific one. Again,
Mhm.
in some instances, right? So, great. Okay, so Mark, I'm going to hand this one to you. Is there a concern in facilitating a quote unquote warm handoff in terms of might that violate HIPAA?
Well, I think you always want to be sensitive to confidentiality matters. So when I'm saying warm handoff, this is going to be in concert with the patients, their agreements to have authorization. So that would be part of the process. So not necessarily reaching out and establishing that contact without having that conversation and being authorized to disclose PHI to the identified new provider.
Great. Jeff, any addition there?
No, I think this area is really um, one in which you have to make sure that you engage in as much risk management as possible to avoid somebody alleging that you engaged in misconduct. It's very powerful to be able to say, well, look, I actually talked to Mark Martinez about this. We made a decision that this is what I was going to try and do. Those were the limits of it. And people need to understand that the more individuals you talk with, the more it becomes arguable that what you did is consistent with the standard of care. Being solo out there and saying, I did it because I thought it was the right thing is okay. And if it's right, that's doubly okay. But saying, well, I talked to Mark Martinez or Lisa O'Brien, or, I have a consultation group and we went through that. All that is really very helpful ammunition when somebody complains about you. Because I think one of the things that people need to remember that um, if you have a happy patient, you're not going to get into difficulty with that. I think that warm handoff is probably a good term to because that makes the transition work, right? But if it's not successful, there's nothing more difficult than having an angry patient out there who really can complicate your life, even though you didn't do anything wrong. So we have to manage the patient. That doesn't mean you give in to them. Doesn't mean you do things inconsistent with what your professional standards are. But an angry patient can keep you busy for a couple of years.
Yes, yes. Okay, great, thanks. So Mark, I'm going to hand this one to you first, which here they say, can a clinician say, I don't write those letters? And I think in this case, they're referencing like disability letters or those kinds of things. So can we as clinicians just say, no, I won't do that?
Yeah, I think you can. You're not obligated to write them. You're not required to write them. I counter that by thinking or balancing that against, what can I write? What is the context? What type of information can I share within my role? Can I answer any of these questions? Sometimes these questions may simply be, is this person in treatment under your care? A very easy question, which I wouldn't refuse to write a letter like that as a treatment provider. And I also think about some of the therapeutic alliance. How much would it be damaged? And is there a strong reason why I would turn this down or refuse to write it? I tend to try to be on the side of professional courtesy and supporting and doing what I can within reason without overstepping my role. So I guess the short answer is yes, you certainly can. You're not obligated to do it, but I would want to have a thoughtful analysis about the reasons why before making that decision.
Mhm. Jeff, any comments there from you?
Yeah, I really think that people need to, when a patient or a client asks you to write a letter, you should stop and think, what does this have to do with therapy? Um, I mean, and if it doesn't have much to do with therapy, then you shouldn't be writing the letter. I think it's Mark is right. Writing a letter saying that John Jones is in it with permission and with consent is in therapy with me is fine. That's actually just fact witness behavior anyway. I mean, it's like they're coming to see me. That's okay. But they say like, well, I want you to write me a letter to get me off of work, or Lisa wrote about this, the famous emotional support animal letter, where it's not somebody comes on and say, well, I've got my little dog and I want to have my dog with me. It used to be on the airplane, but they changed the laws. But in my apartment or whatever, treating therapists shouldn't be doing that. Those are complex questions that require a knowledge of disability, workplace concessions. Or somebody says, I want you to write a letter about special things that I get at work. You don't know a thing about what work has or not has or what they've done. And so it's a great example of why the clinician shouldn't be doing that, because a forensic person who does it analyzes those things and actually can take a look at the workplace. So that question of what does this have to do with therapy? And if it doesn't really have anything to do with therapy, then you don't write it. And I think Mark and Lisa are right. I think you can tell people right up front, I don't write those letters. That's my business model. I don't write those letters. And that's fine.
Yeah, and I completely agree with both of you. And if that is your stance that you're not going to write those letters, I think you can even put that in your informed consent so
True.
that clients that come in, they know that right from the get-go. And then if you do get asked that 3 months, 4 months down the road, you can go back to the informed consent and say, actually, this is in there as well. So that's another way if that's the stance you want to take. Um, okay, so this is a very different sort of question, but still related to disability. What about when a disability attorney is asking for the notes? And here I'm presuming they mean session notes, progress notes, the mental health record. Jeff, do you want to start with that?
I love that question because the fact of the matter is, an authorization to release PHI to an attorney is required by law. So if somebody says that I want you to send my psychotherapy notes to my disability attorney, you have to do it. You probably want to talk about what's about to happen and what's in those notes and whether they really want the attorney to have the information that's in the notes. So preparing the patient with for what's about to happen is extremely important. But what is extremely important for you as a clinician is to recognize that your role is not to serve as an expert in any legal proceeding. You are simply evidence. Your notes are evidence. You don't have opinions about causation. You don't have opinions about damages. And attorneys need to be told that because when you send those notes, some attorneys understand this, but many don't. They'll go like, well, now I want to make you an expert in this proceeding. And you cannot accept that, and they can't make you accept it, making you an expert. Usually, the reason lawyers want to do that is they're looking for cheap help, but they need to go and let somebody answer the psycholegal questions separate from the therapeutic alliance. It's dangerous turf to try and occupy that role. And it really is a boundary violation for which psychologists have been disciplined in the past. So, yes, the notes go. They're not your notes anyway. They're their notes, really. You're the custodian of the record. So, but make sure the expectation is clear about what's happening and make sure the patient understands what's written in them.
Yeah, great points. Great points. And Mark, I'll send this one your way. So let's assume that the clinician is deciding they need to refer out for this disability assessment paperwork. What type of clinician, the question is here, what type of clinician is appropriate referral for a disability eval? Can you give some tips on that?
I mean, I think most commonly, so forensic psychologists, I think the misconception is that they deal with criminal matters primarily or civil court. But broadly speaking, forensic psychology really relates to civil, criminal, regulatory, and administrative type of tasks, those questions, which we're interpreting laws, rule, regulation, administrative policies, and things of that nature, and trying to translate psychology to help whoever is trying to make a decision and needs that information to help them make those law, regulatory, administrative decisions. And so I tend to refer to forensic psychologists with these because I think they have the training and that's really in their wheelhouse. I think you can get plenty of referrals by reaching out to experienced colleagues, reaching out to a listserv. There's plenty of directories. The American Academy of Forensic Psychology, for one, that I tend to go to because I know a number of colleagues who I think do fantastic work. And if I don't know of anybody specifically, I will sometimes offer that directory to those seeking evaluations, whether it's attorneys or people in the community contacting me.
Terrific. Thank you. Jeff, you mentioned this just briefly, but someone did ask about it, so I will give you the opportunity to expand just a little bit. What about letters recommending need for a pet companion? So, I know this is one of your favorite topics. So,
Well, we did what, 4 articles on it. You wrote
yeah.
one of them with us. Those require an understanding of the law. They require an understanding of issues that have to do with disability. For example, people never think about this with the wonderful emotional support animal letter, but that letter is a certification of the existence, and I'll use the legal term, of a psychiatric disability that the patient has that is ameliorated by the presence of the animal. Well, most people who write those letters never even evaluate whether the animal ameliorates anything. And they surely don't know that that requires a disability. It's a disability letter. What's the impact of that? Maybe nothing, or maybe a lot. Because if you write that letter and then 2 years down the road, they want to get a top secret clearance, you got a problem. Because that letter certifies that they have a disability. So if you don't understand the law, if you don't understand the complexity of the question being asked of you, then you shouldn't be doing it. And you can get yourself into trouble. And the truth is, there have been a number of psychologists who have been disciplined by licensing boards for doing just that. That they write these letters because they're advocates for their patients, and you should be an adequate advocate for your patient. That's what good therapy is about. but then you lose your objectivity about the question, and most of them are not familiar with the law or any of the potential consequences of that. They just want to write that letter. So if you ask me if I think clinicians should be writing emotional support animal letters, the answer is no. They shouldn't be writing accommodation letters for apartments. That's the role of trained forensic people who know how to do it, and there aren't a lot. Excuse me. So it's a great and very complex area. And if you don't know how to do it, you shouldn't do it.
Yeah, and I think you're getting there to, well, many points, but one of which happens to be competence, right? You shouldn't do it if you're not familiar with the literature and what's required in an assessment. And it can't be based just because the patient says, I need this animal. That's not
Oh,
sufficient, right?
absolutely, Lisa. I mean, I think the funniest case in point, because the airlines got to hate us for what they were dealing with, and the president of United Airlines said that he thought the thing got ridiculous when a mental health professional certified an emotional support animal for another emotional support animal. So the letter said that the first animal needed the second to emotionally support the first animal. I mean, most of the people out there would say, now that's really ridiculous, but it happened. So it did happen.
It did happen. Well, I have all sorts of comments about that, but for time's sake, we will move on. This is a very different topic, so quick flip of topics here, but are clinicians allowed to keep a client's credit card on file for possible avoidance of payment? And if so, what are the considerations of confidentiality since a credit card may show a name? Mark, do you want to start with that one?
Sure. Short answer, yes, you can keep that on file. I think it's a good idea to keep all fee arrangements clear in your informed consent at the outset and how balances will be treated. I also, when I hear this, I'm very sensitive to the idea of carrying a balance. I sometimes get calls with individuals who have seen somebody for upwards of 30 sessions and they've run a balance, and then they're trying to recoup that cost. And imagine if you were to then run the credit card because they agreed to the informed consent, fee arrangement agreement, and then the person goes and challenges it with their credit card. Well, guess what? It's their credit card. Very often, even if you have a good reason for these charges, the credit card's going to side with the person who's the credit card holder. So credit cards are not a cure-all. I think what's often better is if you're going to have that, um, hopefully that's a safeguard. But ultimately, I think establishing fee arrangements, discussing with patients when there's a balance due, not letting a balance accrue that's very large, exploring the potential clinical reasons. Is there financial hardship that's going on with the patient? Can a payment plan be devised? What's going on, in other words? So, short answer, yes, you can. A credit card's fine. Some people prefer it. You want to really consider carefully how you're going to use it, when you're going to use it, and then also course, an analysis of why this person may not be paying or why I need to rely upon this.
Yeah, I agree. I think what my red flag went up there when they said avoidance of payment, because I think the
Yeah.
thing you want to be very careful of is yes, you should get patients permission to hold their credit card on file. All that should be in writing, just like Mark suggests. I agree. And you don't want to surprise them, right? These are the cases I've seen where it goes badly. Like you say, there's a big bill and then the patient's not paying. So now suddenly the clinician charges everything on the card, and that leads to a whole mess. So the patient should never be surprised by a charge on the card, to be safe. Okay, I think we can get in at least one more. We'll see how long of an answer this is. I think this is going to, well, here, let me just read you the question. So what are your thoughts about continuing to see one partner of a couple for individual therapy after the couple who was your original client has decided to end their relationship, right? So you start doing couples therapy, you work for some time as a couples therapist, they decide to end the relationship, and now one partner wants to continue with that same therapist in individual therapy. Are there considerations different if the couple is legally married and going through a divorce process versus couples who are not married and their dissolution might look different? Jeff, do you want to start that one?
It's a common question. It's a really good question. the question wrapped around you're changing your model. Can you change the model? It's dangerous turf. That is potentially dangerous turf because you're going to be discussing in the individual therapy issues that came from the couples therapy. And so the confidentiality of the individual to whom you have the same legal duty, even though they're not there anymore, is in question. Could you figure out a way to get a consent and an informed consent so they say, I don't care if you continue to see my husband here, I authorize you to freely discuss with me, with them, the issues that have to do with me? Yeah, that you might be able to pull that off, but remember the old the danger is in an angry patient. So let's say you've done couples therapy and then the one you continue to see decides to divorce the one that still wants to keep the relationship going to whom you have the same duty, you got a real problem there. So to keep it squeaky clean, I think it's better to just do one job. Is it possible? Yes, but it's dangerous. It has risk with it because that individual who wants to maintain that marriage, and you're doing therapy with the person that wants to end it, may see you as the problem.
Mhm. No, great points. I agree with you that I think the risk is very high there. And we hear this a lot, and Mark, I'd be interested in your take too, but we hear a lot, oh, well, the patient agreed, so it's not a big deal. And I think sometimes that can be helpful, but that does, from my perspective, that does not put a clinician on solid ground. If you're going to be
Right.
facing licensing board, in some ways, they're not going to care if the patient agreed or not, right? Because the responsibility is still on us, the clinician.
Right. Yeah, I
Mark, we're
completely
about
agree.
to end, but anything you want to add there real quick?
I completely agree. And I think that example that Jeff gave is one of those that we may not be able to foresee in the moment, but it's certainly a possibility. And
Mhm.
it's important to attend to that. And in order to be conservative, it's probably best to keep those roles separate. We also want to appreciate that relationship that we established with them. We're bringing that into the room as Jeff suggested. And to what degree is that going to affect the relationship that's being established, the new one? So if you're going to do it, do it very cautiously with a lot of forethought.
Yeah,
Yeah.
beautiful. Thanks to both of you. I'll just add that's another one of the situations, right? Lots of complexity, so please consult. Thank you to both my colleagues here, Mark and Jeff. You guys are great as always.